Okay, so I'm gonna go ahead and start by presenting the first case. This is actually one of my patients that has CS at Tampa General. They ended up getting transferred over. But the patient is a 64-year-old male with a complex past medical history. So he had CAD, status post-7 stents, hypertension, hyperlipidemia, most importantly, psoriasis, and previously was on Humira. And he presented to the outside hospital, interesting, after a fall off a ladder. So he actually fell off a ladder, suffered a lumbar fracture, and incidentally was found to have pancytopenia at the time. And so these were his counts, low blood counts as you would expect for the diagnosis. But what was a little bit different is he had high inflammatory markers. So his ESR, CRP were elevated, his ferritin was elevated. He had a lot of joint issues, specifically severe joint pains in his bilateral knees that was limiting his ability to do much activity and kind of kept him in the bed during this time of his initial diagnosis. We did the bone marrow biopsy. It showed that he had acute myeloid leukemia, 50% blast, background dysfunction of the cells. He had a monosomy 7, and on the first NGS, he had a PTPN11 and a RUNX1 mutation. And so for this guy, he was, because of his fitness status when he got to us, we started him on Vidaza-Ven, which is our standard of care therapy for elderly unfit patients in AML. He, again, had significant knee pain. He actually spent 2 cycles in the hospital because of debilitating knee pain, despite seeing rheumatology, et cetera. But after the 2 cycles, he got into a CR and his knee pain and his joint symptoms resolved. He then, was out of the hospital, dealing with some other things, was on therapy, then had relapsed acute myeloid leukemia, came back, recurrent severe joint pains, and then the repeat NGS was done by GTC, and that's what we're gonna discuss on the next couple slides of this presentation. So I'll switch it over to Maher.
Thank you. So just to be clear, the first NGS wasn't done at our laboratory. It was done at a different laboratory using a panel that it is limited panels. And we all know today there are some insurance companies that you shouldn't be using more than 50 genes for hematologic diseases, and some they say no. But just this one example to show you how important. So the first mutation that we found is UBA1 mutation in this patient. Since the patient had a germline mutation in MUT-YH genes, but has a somatic mutation in RUNX1, PTPN11s, and of course the molecular, in my opinion, always should be able to tell you the chromosomal abnormalities. They add a whole new dimension to the chromosomal findings. So as you can really see, these are the data on this particular patient. The UBA1 mutation detected at 80% in this patient. This is classic for VEXAS. So the patient has VEXAS in addition to the acute myeloid leukemia. And just to explain it here, so VEXAS stands for vacuoles E1 enzymes X-linked autoinflammatory somatic syndrome. The gene located on chromosome X, so we see it mainly in male, and we rarely see it in female because, again, female has 2 X's versus in the males, 1 X, and always actually we see actually the mutation in patients who have symptoms with a level greater than 80%, which means like 80% of the cells, they have the mutations. Of course, you can really see the mutation in the other genes, especially in the RUNX1 and MUT-YH is at 47%, which means in all the cells, but because it is on autosomal gene, chromosome, so you can see it's in around 50%. Now, and with the cytogenetic, of course, we can see this -7. We were very lucky to start really testing for VEXAS even in 2022, because we've been working with the NIH, and the disease described actually in 2022 in New England Journal of Medicine paper, and they contacted us actually, and we added this gene to our panels, and we've been testing for this gene. We have a huge collection of a mutation. I should really point out that the mutation here is at amino acid 597. That's extremely rare. You don't see that. Usually patients with VEXAS, the mutation at amino acid 41, almost 91% of the cases at 41. And there are some laboratories that test only for amino acid 41, so they would miss even this particular mutation. And striking about these cases, like these patients, most of these patients, they have immune phenomenon, and usually they go from hematologist to rheumatologist, and rheumatologist sends them back to the hematologist, and the hematologist sends them back to the rheumatologist in the olden days before the gene was discovered. And I have, some patients with going to 4 or 5 different academic centers and not really discovered the disease. So sometimes we see low-level mutation. These are examples of different patients with additional mutations that usually you see in MDS. But and sometimes we can really see mutation add up to MDS. I must say this is the only patient I have in our database, and our database is most extensive that had AML. Most of the patients, they are with MDS. As a matter of fact, there are some patients with even JAK2 with myeloproliferative neoplasms, and everybody believes that when you have this inflammatory process, the disease is different from your regular AML, because, as you know, the microenvironment of the bone marrows with the leukemia or the MDS is also driven by the immune system as well. And if we look actually, because we do RNA expression, as you can really see here, we see we don't see anything that it is very unusual about the B cells or the T cells. They are there. And in addition, we see, of course, the CD34 at high level as compared with the normal control shown here. But overall, most people believe that the lymphoid system is not involved in the mutations. It's, there's very little studies done on this because these cases are rare. But I can really say it is approximately 1% of patients with MDS. So it is really very important to test for it. And as a matter of fact, we use a machine learning system for making diagnosis. And as you can really see here, our machine learning, by comparing with the huge database we have, I can really go over this at some point later. But it really classifies it as in between MDS and AML, and that's mainly because of the inflammatory process in this patient. And for the sake of time, I'm gonna go fast. This is from recent paper, actually in blood, and again, these actually this is not necessarily representative. These are looking these graphs showing patient with UBA1 mutation versus those without, but all the one without, they are patient considered MDS without typical MDS mutation. So it is not necessarily representative for what this disease and the outcome and the clinical behavior of this disease.
Yeah, so I just want to speak on this a little bit too, because I think this is really clinically relevant and relevant for, let me hold this a little closer, relevant for, all the different companies, all the different therapies. Because the reality is that until we started testing for this mutation, we did not necessarily recognize that the percentage of patients that had this particular mutation had this particular disease. And so we see commonly in our clinic patients that were not tested for it, have some sort of autoimmune phenomenon, might not have the entire what was described in New England Journal of Medicine, but have, an autoimmune disease, and then we incidentally find this UBA1 mutation. And I think it does sort of change the way that we think about the patient, think about the treating disease, working closely with rheumatology, and I think it probably affects the way that patients respond to individual therapies. And so, I think it's exciting to be able to start discovering these new mutations, and I think it's going to be continued clinically relevant. You have to make a decision. Do you kind of stick to your traditional treatment for MDS, or do you sort of move to a therapy that might be able to work on the MDS, but also help with some of the autoimmune phenomenons in the setting of VEXAS? And I see we have some questions, so